Health and Human Services Policy Committee will come to order. Members, we've got a lot to cover today, and I want to remind everybody that since we're going to finish hearing the Minnesota Insurance Marketplace bill, and we're going to vote it out today, so if we don't get through with our business during this next hour and a half, or slightly less than that, we do have the room reserved at this evening. And so just to remind everybody, we'll be recessing, we'll be reconvening at 8 p.m. or 15 minutes after the State of the State is finished in this room, if we need to do that. I really hope that won't be necessary. We do have a lot of amendments, but I think that we can get through them in a pretty timely way. And we are going to start with we're going to start with testimony from folks who were not able to get their testimony in yesterday. So, do we have a quorum? So a quorum is present, and I think what we'll do first of all is if I can get a motion to approve the minutes of January 30th and February 5th. We need both of these. Representative Joanne Ward moves to approve the minutes of January 30th and February 5th. All in favor of that motion, please say aye. 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 All opposed, no. Thank you. The motion prevails. The minutes are approved. Thank you, Representative Ward. So we're going to start now with testimony. Oh, sorry, Representative Mack.
Thank you, Madam Chair, and I look forward to beginning the testimony. I did have a question just in regards to kind of the roadmap for today, and you did just give a good amount of direction. But just kind of following up from yesterday, there's I know still a lot of outlying questions for testifiers from yesterday. It was a little bit frustrating yesterday. We had members on the list with clarifying questions that weren't recognized, and I understand that we were short on time, and it was alluded to that we would have time to bring those testifiers back today to get those questions answered and clarifications made. And I guess I'm hoping and trusting that plenty of time will be given for that. Obviously, this bill is enormous. Pretty much every aspect of it is under the purview of this committee. And as you know, people from your side of the aisle have said, this is the biggest change since Medicaid and Medicare into the health system. And so I guess, Madam Chair, I'm asking for that courtesy to have the opportunity to ask as many questions as we need to of the testifiers in order to try to get at understanding this bill and its implications for Minnesotans.
Well, Representative Mack, we are giving this bill plenty of time. As I did indicate, we are willing to come back after the State of the State. We've got the rest of the day. We do have a lot of amendments which we're going to be taking, and it's important to understand, I think, for the public that this bill is going through a lot of committees, and it is true that our jurisdiction is very broad. We do want to vet the bill thoroughly. On the other hand, when questions are, I regret that we didn't have more time yesterday. Certainly, we're making some of our testifiers wait until today to get their testimony in. And I think we, everyone, probably me included, would like to have engaged in some discussion with some of the testifiers, and we didn't have time to do that. However, clarifying questions need to be really clarifying. And if we're going to interrupt people and make people come back the next day or not let them get their testimony in. So I think we'll have a bit more opportunity today, although members who have, many of these are GOP amendments, as I understand. And if we want to get to them, we're going to have to at least keep our comments and our discussion pretty concise and ask questions that we really want to know the answer to. And I think if we can all kind of keep our speechifying down, it would be very helpful in getting through this. The fact that the deadline for this is very short is unfortunate, but as everybody knows, we need to get this through in a very quick fashion, and it's moving along pretty well so far. And we've had, in the last couple of years, this could have been done. There could have been plenty more time to be worked on, to have this worked on, and unfortunately, the Republican majorities weren't able, for whatever reason, to do that. So that's why we're in this very short time frame, and it's kind of too bad, but it is what it is. So we'll just try to all hold hands together to the extent we can, and get this thing through. Representative Mack.
Well, and thank you for that, Madam Chair. And I do understand and appreciate the very tight timeline that we're under, and I think, speaking on behalf of my colleagues, and I think it's fair to say it for the folks on your side of the aisle, we're ready and dedicated to give any amount of time necessary to truly vet this bill, whether it means late nights or thus far. And I guess just, moving forward for the sake of the committee, Madam Chair, earlier this morning in Health Finance, I'll commend Representative Huntley. I know it was very much appreciated. We had 24 testifiers in that committee testifying on the governor's budget. He took questions in between. We've finished a few short, but I think that was an effective discussion that we were able to have by being able to ask testifiers questions as we went, and was even told by testifiers that was appreciated so that they can adequately respond to comments they just made. So I guess maybe that request going forward, and I've talked with my colleagues, and we really intend to keep our discussions to the bill, honing in on concerns and issues that are important to make this bill better as we go forward. So with that, we can move on, Madam Chair, and thank you for letting me share those concerns.
All right. Thank you, Representative Mack. I just want to, say that I think it's very different to just take testimony on the budget, and there's time to do that, and we need to all fully understand that for sure, but there's no bill there that has to be voted out on a deadline. So I think we would all prefer that, and we'll just do the best we can here going forward. So we're going to start with testimony if Jonathan Watson is here. And after we get done with these three testifiers, we will then bring Representative Atkins to the table and move his bill. So the bill isn't officially before the committee, but we'll continue with the testimony as we did yesterday. Welcome to the committee.
Great. Thank you, Madam Chair. Members of the committee, my name is Jonathan Watson. I'm with the Minnesota Association of Community Health Centers. We represent the state's 17 federally qualified health centers. I just want to briefly point out 3 points of the bill today, House File 5, that we support. We have 185,000 low-income patients we serve. They are going to be heavy users of the exchange because they have very low incomes, 95% below 200% of poverty, and 70,000 of these folks are uninsured. So they are going to be heavy users of the exchange. The first issue I want to talk to is the governance piece. It does say in the language that there is a board member with expertise in the area of Minnesota healthcare programs and uninsured. We applaud that. That's actually 82% of our business. In terms of the healthcare, the task force of the health exchange, we did have FQHC representation on that committee and felt they brought a lot of issues from the low-income communities of color perspective. The second point I want to bring up is with navigators and in-person assisters. It appears to me in the bill that there is money set aside for in-person assisters and navigators that would include staff at community health centers. We've been doing this for 40 years at community health centers. We just didn't know there's a fancy name for it. But enrolling folks in public programs really is for our own financial viability. The uninsured, if they're eligible for programs, we try to get them into those programs because there seems to be an infinite number of uninsured that we serve every year. It increases by 11%. So we do applaud having the navigator in-person assisters portion of the bill. The last piece I want to talk about is the health carrier plan requirements. What works really well in the state right now is the state's essential community provider law. That mandates that all HMOs need to subcontract with an essential community provider, which oftentimes is a safety net provider that coordinates care and is essential to care in that area. We would strongly recommend that you extend this provision to the qualified health plans underneath the exchange. This isn't very explicit in the bill right now. We'd recommend that this become part of the bill at some point or other legislation this session. So those are the 3 things I have for you today. I can stand for any questions. We strongly support a Minnesota-made exchange that really reflects the diversity of the patients that will be using it. Thank you.
Thank you, Mr. Watson. Next up is Kelly Wolf. Welcome to the committee.
Good afternoon, Madam Chair, members of the committee. My name is Kelly Wolf. I am the Senior Policy Specialist at Children's Hospitals and Clinics of Minnesota. Thank you for the opportunity to speak with you today about our concerns on behalf of Children's. Children's Hospitals and Clinics is Minnesota's largest pediatric provider of cancer care, neonatology care, cardiac surgery, and diabetes care. We provide care for many of the sickest children in the state and serve patients from all 87 counties in Minnesota and 65% of the counties in our bordering states. Children's turns no child away, regardless of their ability to pay. As a result, Medicaid now makes up 42% of our revenue, which is in stark contrast to the average adult hospital of less than 10%. And despite the fact that children make up 50% of Medicaid enrollees, they actually only account for about 20% of the cost. So we know that investing in children's health care now saves more in the years to come. Given this, we are acutely aware of the importance of insurance access and coverage, and we believe that the establishment of a Minnesota-based health insurance exchange is a positive one for our state. However, given the complex and new nature of the exchange, we do have some concerns about the inclusion of comprehensive pediatric health care services in the product offerings on the exchange. Understanding that one of the goals of the health insurance exchange is to create greater access to care, we need to continue providing families reasonable access to pediatric specialty care services that fit their unique needs. While adults have access to more than 140 hospitals across the state, there are less than a handful of pediatric care providers, each of us with unique areas of expertise. No one predicts or plans for the type of conditions and situations that bring their child to us. But when faced with that situation, there should be no barrier to care, to the kind of care that these families seek. As a state, our job is to plan for that uncertainty by ensuring that all the products maintain access to the state's pediatric specialty care providers. In 2012, we took care of over 2,000 babies in our neonatal intensive care unit, patients whose care was often costly and complex. Because of this highly specialized treatment, premature babies can require long hospital stays, the average being around 19 days. In fact, many of our babies spend more than a month with us, and a 1-month stay in our NICU averages a charge of approximately $195,000. Our understanding is that an out-of-network provider could place patient financial responsibility between 70 to 90% of those bill charges. That financial burden would be devastating for a majority of our families and contribute to an already stressful situation. If a pediatric provider is only available as an out-of-network option, families will face such extreme out-of-pocket costs that they will forego the most appropriate care, or more likely, get the care that their child needs and essentially shift the financial burden to the rest of the healthcare system. While we hope that all births result in healthy children, the reality is that they don't. And for those children who need our services, our doors are and will always be open. We need to ensure that every child and any family in need of our NICU, cardiac, or oncology care, our services are covered by all the products on the state's insurance exchange. We are monitoring the development of this legislation closely, and we look forward to working with you and the author as this legislation and others move forward to ensure adequate access and coverage for pediatric care services. Thank you.
Okay, thank you, Ms. Wolf. And I do have a member on the list. Representative Grunhagen, is it a question to this testifier?
I'll wait till after the testimony.
Okay, that would be great. We just have one more, and then we can take a few minutes for some comments, and then we can go to our amendments. So, Todd Mickelson. Welcome to the committee, and thank you for coming back today.
Thank you. Thank you for allowing me to come back. Madam Chair, members of the committee, I'm Todd Mickelson, and I own a small business that I built around a patented invention of mine. And we assemble and test this and other items that I've developed in our facility in the old Tonka Toys building on Lake Minnetonka. And we sell and export these to countries all around the world. You may have seen an article in Sunday's Star Tribune business section last week in which I was featured. I talk about the troubles that we as a small business have had securing small loans and credit, and that we feel as though we've been penalized just for being a small business. We also feel like we're in the penalty box when it comes to the subject of health care insurance. Being small business owners, we must secure our own health care coverage. My wife and business partner, Heidi, spends a fair amount of time managing this. She, my 9-year-old daughter, Eve, and I are pretty healthy people. We take pretty good care of ourselves and rarely need to see the doctor. I developed a nasty rash on my leg last summer that I thought for sure would kill me by the end of the weekend, so I went to urgent care, and they told me, of course, to just chill out and that it was poison ivy. But I, of course, had to pay for that debacle out of my own pocket. And dental coverage is out of the question. It's prohibitively expensive for us. So, of course, regular trips to the dentist are also paid for out of our pocket. And if our daughter were to break her arm, it would cause us to take on debt just to pay the very high deductible, even though we pay hundreds each month in health insurance costs. It feels as though we have no health insurance at all. So my wife, Heidi, continues to constantly be on the lookout for a better deal for our insurance, spending a fair amount of time at it, which we feel is another penalty on small business owners. Now we're faced with the possibility of growing our business, which you think would be a good thing, and it is. And we hope to go through with our plan to try and do that in the next couple of years. But like other small business owners, we're waiting to see if also providing employees with health insurance is even going to be possible. So we're very excited for the changes being made. Heidi's looking forward to an exchange where she can easily compare health care plans. And we very much hope that the Minnesota Health Care Exchange bills pass with the provisions that allow small businesses to have the same advantage that large corporations currently have with group rates and other things. This would greatly encourage us to more vigorously pursue our plans to grow our business and create more jobs in Minnesota. We also strongly believe there should be a representative for small business on the Oversight Board and would be gravely disappointed if the conflict of interest provisions did not survive. Thank you very much.
All right. Thank you, Mr. Mickelson. Again, appreciate your being able to come back today. So, Representative Grunhagen.
Oh, thank you, Madam Chair. I've got just a question for Representative Atkins. And I've got two questions and just one observation. I know we're tight for time, okay?
Welcome, committee, Representative Atkins.
Yeah, Representative Atkins, we didn't get a chance to finish our discussion. Were you able to review the article that I gave you where the IRS predicted that the bronze plan for a family of 5 would be $20,000 per year?
And Madam Speaker, Representative Grunhagen, we do have a representative here from the Insurance Exchange who I think can articulate that. As I told you yesterday, I think we're talking a little bit of apples and oranges. The reference that you made, the article that I believe was it CNS or Christian Science or Christian News or something, and I appreciate your sharing that. But I think what we're talking about is something that's different from what we're doing in the marketplace itself. But Ms. Momlov is here, and she may be address that a little bit more specifically for you, if that's all right with the Chair.
Sure. Welcome to the committee.
And if I might just finish my thought, then I'll turn it over to Ms. Momlov.
Sure, Representative Atkins.
Thank you, Madam Chair, and thank you, Representative Grunhagen. My understanding, and I looked at unfortunately the article is a page, but it doesn't really cite its references, and I didn't have a chance to look at the IRS code that was, I think what the IRS did was they put out some possible sample costs for what it may well cost and then the impact that, and this is of Obamacare or the Affordable Care Act generally. And they talked about what those costs might be and then how that would particularly impact a certain set of taxpayers. What we're talking about when people go online to purchase their health insurance is something separate. I don't doubt that there's some additional costs that will follow with the Affordable Care Act when you're not allowing for pre-existing conditions to ace people out of getting coverage and so forth. There's some cost drivers there. And I know the health plans passed out some, I don't know if it was in this committee, Madam Chair, perhaps the previous one, that referenced some costs that will go up. What we're talking about in the exchange, though, is the average family saving $490 a year, and some families saving as much as $1,700 or $1,800 a year as a result of two things. One is competitive apples-to-apples comparisons between plans, and then secondly is being able to avail themselves of the tax credits. That was just kind of where we left it off yesterday, and then I've also got Ms. Malmoff that can add a little bit more detail.
Okay, thank you, Representative Atkins. Ms. Malmoff.
Madam Chair and Representative Gruenhagen, I have just literally gotten the article, so I have not had a chance to read that. So my response probably won't be as detailed as when I could
And
look
Ms.
at that.
Malmoff, could you just give your name for the
Oh,
tape so
yes.
we'll get you down?
Madam Chair, April Todd Malmoff, the Exchange Director. So what a family will pay on the exchange really depends on what their income is and what level of tax credits that they would be eligible for. And so the tax credits are available for people between 138 and 400% of the federal poverty level. So it really depends on where along the scale that their income would be in terms of what premium they would pay. It's a scale of between 2% of income versus 9.5% of income on that scale as to the percent of their income of what they would pay in premiums. And so this may be an example. And again, I haven't read this in detail, but really it will vary quite a bit based on what someone's income is.
Madam Chair, follow-up?
Representative Gruenhagen.
Yeah, one of the claims that are made about the exchange is it's going to create lower cost premiums for people. And yet, when we look at the Massachusetts exchange, which this is patterned after, we see that health insurance premiums did not go up. They went exponentially, or they did not go down. They went exponentially up. So do you have a credible example, and Representative Atkins, feel free to chime in, do you have a credible, objective example anywhere in the United States that this type of an approach that we're talking about with an exchange actually reduced premiums, increased access to health care, and produced better outcomes? Because everything I've looked at, and I've studied as much as anybody, you probably know that, I hear all these claims, but there's no objective data to support it. In fact, the objective data points just the opposite. Higher premiums, less access to health care, and less quality outcomes. Would you respond to those? Do you have any objective pilot projects that actually show better results or some of the claims that are made publicly on this exchange?
Who wants to take that?
Well, I would.
Representative Atkins.
Thank you, Madam Chair, and thank you, Representative Gruenhagen. I want to make one point, and then I want to have Ms. Malmoff talk about the differences between Minnesota and what's occurred in Massachusetts. The most important point that I can make for you is there will be an exchange in Minnesota. Without a doubt, there is going to be an exchange in Minnesota. The one that we are proposing here, though, is a Minnesota-grown exchange operated here in Minnesota, guaranteed to cost less. We know that already than what the federal government would impose upon us, because the premium withhold that's being used to fund it, guaranteed, is lower than what's guaranteed in the federal health exchange. With that, and then what I'd like to do is have Ms. Malmoff talk a little bit about the differences between Minnesota and Massachusetts, and then if I might reserve just a few seconds at the end, Madam Chair.
Yes, and Representative Atkins, before we go any further, I would first of all like to move your bill and get it before the committee. So I'm going to move that House File 5 be recommended to pass and be re-referred to the Committee on State Government, Finance, and Veterans Affairs. So with that, please, Ms. Malmoff, go ahead. We now have a bill in front of this committee.
Madam Chair, Representative, so Massachusetts is the one example that's out there. There is one example to rely on. There are some differences between Massachusetts and actually what's in the federal law. So the first one is just the difference in how the tax credits are structured. They're different in Massachusetts than they exist under the ACA. I would say Massachusetts focused quite a bit on increasing coverage. They did not have some of the provisions in place that would deal with some of the risk sharing mechanisms back and forth that are needed to needed to control some of the risk mix that's there. And so one of the things that's in the ACA that was not in the Massachusetts exchange was around risk adjustment. And so under the ACA, risk adjustment applies inside and outside the exchange. Massachusetts did not have that in force. I think one of the some of the few things that we can learn from Massachusetts is that they did experience a dramatic reduction in their uninsured population, and they saw an increase in coverage in employer-based coverage. So those are some of the things that we've learned from Massachusetts and how they have been a bit different.
Madam Chair.
Representative Gruenhagen, I'm going to let you ask one more, and then I'm going to go to Representative Mack.
Okay.
That's okay.
Yeah, so basically what I hear, though, there isn't a objective, repeatable example that you can point to where premiums actually came down, okay? And that's the problem. We make these statements of lower premiums, and they're not coming true. And we can see that with the cost of the ACA, which has tripled since it first came out. It's gone from $969 billion up to, according to the CBO, up to over $2.7 trillion, okay? And the result is that it is not going to help the doctor-patient relationship by spending hundreds of millions of billions of dollars. It's going to hurt the doctor-patient relationship, which would have been my next question, but I'll defer to
Madam Chair, Representative Gruenhagen, I know you don't like the Affordable Care Act. I get that. But there is nothing about operating a marketplace that will drive the cost of the products higher. It will only drive the cost of the products lower, as there is apples-to-apples comparison where people can actually do some shopping in a transparent way to find a product that fits their needs.
Just one comment, Madam Chair, but there's not an example where it actually does that. The only example is Massachusetts, and we see premiums rising exponentially. So I guess when statements are made that premiums are going to be lower, it'd be nice if there was some objective, repeatable facts behind those statements, rather than just, I feel like it's going to be this way.
Representative Mack.
Thank you, Madam Chair. Just a couple follow-ups along those lines. I guess, Representative Atkins, you said that this is guaranteed to cost less. It's a Minnesota homegrown model. I guess where I tend to get confused, and I'm hoping at some point we'll be able to bring a couple other testifiers up that I think had some interesting information from yesterday, and maybe you can refute that. But this question is in regards to, if I understand it, we're going to be making the benefit set bigger. We're going to be lowering the amount of money that the participants are paying in. The combination of those two, according to most insurance experts that I know, invariably product costs go up. And so I guess if you could just walk me through specifically, whether you or Ms. Melmilov, the process and how this compares to the federal exchange, exactly how we get to the $490 to $1,700 savings per family. I haven't seen a model. I haven't seen a chart. That number keeps been thrown around, but I've seen nothing concrete. I have no idea how we're getting to that. If you could go through that in some amount of detail or clarification, that'd be really helpful.
Representative Atkins.
Thank you, Madam Chair. Thank you, Representative Mack. There's two pieces to your question. One is the operating costs of the exchange. That's what I referenced with respect to Representative Gruenhagen's question. The second piece of that is the $490 that's anticipated by MIT's health economist that will be saved as a result of participation by families in the health exchange. On point number one, and the reason I can guarantee that it will cost less is because under the federal law it says it will cost 3.5% of the premiums will be withheld. In Minnesota we anticipate about 2.25, and we've put in the language itself that it says up to 3.5. The latest figures that we have based on the participation that we expect, it will be in the neighborhood of between 2 and 2.5% of the premium withhold. That's why I've indicated repeatedly that I expect the cost will be less. With respect to the $490 that's anticipated, I'd expect that Ms. Malmlov might be able to give a little bit more expeditious answer than I would.
Okay. Can I ask one follow-up?
Yeah, do you want her to answer first?
I just have one question to the first point,
Mack.
just to keep it delineated. That's very helpful, Representative. I think I was misunderstanding what you were saying were the cost savings. You're referring strictly to the operating costs. And the 2.25%, at what point do we commit to that number? At what point is that the number that we start using as the withhold? Is there a follow-up bill? Is there, who decides what that number? I'm assuming it's the exchange board, but if you could just clarify that. And at what point do we commit to plans and consumers? We're holding that withhold at 2.25. We won't take more than we need. We know it's going to cost this much to run the exchange. So here's our withhold, and we're saving you money over the federal. At what point does that decision get made?
Representative Atkins.
Madam Chair, Representative Mack, I think you answered the question, as we are entrusting this board with the expectation that they will not charge more or less than they need to operate the functions of the exchange or of the marketplace.
Representative Mack. Okay. Did you want Ms. Melmoff to answer?
No. Well, yes, and Melmoff to answer the second part of the question. I guess to that, I think, and we'll probably talk about this a little bit more down the road, but I understand you're correct. That's what we're entrusting this exchange board to do. That, of course, begs several other concerns and questions, given the fact that they don't have a whole lot of oversight from the legislature or the ability to understand the transparent costs of what this exchange is going to be running the participants who are using it. So I understand that we're entrusting a whole lot to this board with very little ability to follow up and find out, are they actually justifying the amount of money they're withholding, and how do we know that, and how do we as participants and elected officials who are trying to represent Minnesotans, how can we be certain that that is in fact what this board is going to do when we have very little oversight over them according to the bill as drafted?
Madam Chair and Representative Mack, I appreciate that concern. I share it. We actually have considerably more control over this potential board than we do over the PUC, for example, or the Minnesota Zoo Board, with all that's been built in, not just through state, and perhaps that's in your packets already. There's a full page of the oversight elements, not just from the state, but from the feds, relative to audits, relative to the appointment process, the confirmation process, the subject to the scrutiny of further legislative review, and so forth. If it's not, I can certainly see to it that it is placed in your packets. But that's the sort of scrutiny that's already built into the bill. But I share your concern that it certainly ought to be able to withstand any sort of scrutiny that we want to place on it.
Okay, I have Representative Huntley and Representative Albright on the list, so I think we'll go to those two, and then we'll maybe start to take some amendments, and of course, we can continue the discussion around.
About the 490.
Oh, I'm sorry, did you need to get the...
Just the second part of that question on how exactly you're getting to the $490 to $1,700.
We'll let her answer that, and then we'll go to Huntley and Albright. Ms. Melmoff.
Madam Chair, Representative Mack. So what we did, one of the first studies that we did was we engaged Dr. Gruber and Bella Gorman to do some analysis of what the impact of the ACA was broadly on Minnesota's market, and also the impact of the exchange. So I want to really highlight the fact that there are two separate impacts here. There's one impact that is on the market as a whole that the exchange has no impact on. And then there's a separate impact from the exchange. So I want to highlight there are two separate impacts here. So in terms of the impact on the market, there are changes that are happening under the exchange, under the ACA that are market-wide. And those are the requirements for essential health benefits set, for the actuarial value levels, guarantee issue, the elimination of health status rating. Those things are market-wide and are not specifically related to the exchange. And so we engaged Dr. Gruber and Bella Gorman in figuring out what those impacts would be to the market. And so we have highlighted in a report from them that we got last April in 2012. We have some updated results from that we released those initial results right away. A report will be coming on that soon that has those highlighted details behind that in there. But just to specify kind of what the impact was on the broader market is the broader market is going to have more comprehensive coverage as a result of the ACA than they do today. And that is an impact of around 4% increase in premiums because the actuarial value will be higher and the essential health benefit set applies market-wide. So there is an increase there related to that. We've also looked at what the impact is of MSHA moving into the individual market because people will no longer be denied coverage. It will be guarantee issue. There won't be pre-existing condition exclusions. That population goes into the individual market and they have choice of products as opposed to just being able to get products through MSHA. There is a differential there of between 15 to 21% of the impact of moving MSHA into the individual market. And then there also is the new risk mix of the individual market, the risk mix changing. So and there's a difference there whether we bring in the population that is currently eligible for Minnesota Care or not. You'll have more people coming in that are uninsured that may have induced demand from now having access to coverage, and there is an impact there of between 6 to 11%. That is the impact on the market from the ACA, not the impact of the exchange. Then there are some other impacts just specifically related to the exchange that are also included in those estimates. One is what's called a managed competition effect. And essentially what that means, it's not from active purchaser, which I know others have mentioned previously. It is from the fact that the second lowest cost silver plan is what the tax credits will be based on. So carriers will be competing quite vigorously to become that second lowest cost silver plan because that's what many people will enroll in. And so there is a managed competition effect there of 7.5% that would bring those premiums down. In terms of the $490, where that is coming from, is from the tax credits that people will be eligible for in the exchange. So individuals participating in the exchange, 70% of them would be eligible for the tax credits. And that's where their premium is limited to a percent of income, and they get the benefit of the tax credits. Including the tax credits in that amount reduces individuals' premiums of an average of 34%. So those are the two differences between the market as a whole and the impact of the exchange specifically.
Okay, Madam Chair.
Okay, thank you. Representative Mack.
Just a brief follow-up. Obviously, this Gruber and Gorman report is critical to understanding these and how this is all being modeled. And I understand that a lot of what we originally had was from April, and it's clear that there's been a new report that came out, I understand, sometime last fall or November or December. And I guess it's a bit troubling that we're halfway through the committee process. And I have a correspondence with the department that they're clearly using numbers that we don't have access to seeing. They refer to the new report, have asked where we can find that, haven't been able to get access to that. And so I guess I'm making a formal request that that is put into legislators' hands immediately. And I know I'm hoping to be able to call down Ms. Commit from the Council on Health Plans. She handed out, and this is based on the April report, but kind of spells out some of the differentials and the numbers that you did and how the premiums will be impacted because of those changes. And according to her document, and I think Representative Atkins had this from yesterday, but doing the math, it's on average a 29% increase in premiums based on those numbers. And this is from the April report. You are citing the more recent report numbers. And so I guess that's obviously something to discuss. That's showing an increase in premiums. And then, two, just asking that we get that report right away. It's very difficult to have this conversation, understand these numbers and modelings when we only have half the information and the exchange board, you and the department have it, but we're not able to get access to that.
Ms. Malmoth?
Madam Chair and Representative Mack, so we got these results from Gruber and Gorman on January 11th. They were presented at the Exchange Task Force meeting. Those results are available on our website. We wanted to make sure that those results got out as soon as possible. We are working back and forth with Bella Gorman and Dr. Gruber to get the text for the report done. That should be done very soon, and we will make that available to the committee as soon as it is available. But this presentation slides that have the results that I was just mentioning are available on our website, and I think we have provided that to the committee.
Okay. Thank you. Representative Huntley.
Madam Chair and members, this is a comment, not a question. Mr. Gruber from MIT was ranked as one of the top 20 young economists in America recently. And if you look at his results from his predictions for the Massachusetts plan, everything was within a couple of %. So he did an outstanding job in predicting what would happen in Massachusetts. And lastly, I would say that words mean something, and the word exponentially means a tenfold increase at least. And nobody I've heard of has ever said this was going to be a tenfold increase.
Thank you, Representative Huntley. Representative Albright.
Thank you, Madam Chair. Representative Atkins, isn't it the case that the carriers are going to submit their rate filings and product filings for approval to the Commerce Department and then go through another process of approval to be certified as a qualified health plan through the exchange? If there is that process and then they have to additionally go through the rate filings and the product features what's left for the Hicks Board to negotiate?
Representative Atkins.
Thank you, Madam Chair, and Representative Albrecht. I think we referenced it, and I apologize for not being able. I'll work my way over this for a little bit. Yep. There's three things. You've got the traditional Department of Commerce role, which will be unchanged. You've got the second level of certification required by the law that would say certain levels of relative to the certification that the plans would need or the products would need to meet in order to be sold in the exchange. The final piece that's in the current draft that the board would like is an ability to work with those individual products or plans being offered or products being offered by certain plans to talk about the features that would be included in those and negotiate those features. No different. I think the reference I used yesterday was if you go to buy a car, we may not be able to negotiate over the price of the car. Once you've settled on a price, but now you want floor mats, or now you want to maybe they'll throw in a sunroof on something. It's that sort of ability that the board would like in order to get those add-ons. And I know that there's been some concern raised by the plans about this being an arbitrary kind of thing where they could still meet all of the criteria and then get bounced out anyway or not be able to sell their product. And I'm concerned about that myself. We're still trying to work through and get our heads around what might be a good way to work out those issues. But the point of having that ability to negotiate is to get those extra values that just make a product even better for the consumer.
So thank you, Representative Atkins. And it seems like a good, relevant moment for me to move. Oh, I'm sorry. Do you have a follow-up to that?
Representative Atkins, and maybe this is also from Ms. Melmov. Coming from a finance and a kind of an insurance background myself, we often talk about what's inside the black box in terms of the underwriting or the creation of the beast, if it will. It certainly seems as if we're dealing with one here. If you could provide a flow chart in terms of that process, I'm sure that you've put one together because obviously you're more learned than this. I'm just new to this process, as has been told me. And so if you could provide a flow chart that shows how the active purchaser protocol works, I would greatly appreciate it, and I think everyone on the committee would appreciate it as well.
Okay. Madam Chair, Representative Albrecht, thank you for the suggestion. I'm not real good with, as the exchange folks know, I just tried doing something to show them a screenshot of what something that would look like, and they kind of laughed along with me at my efforts in that respect. But I think that's a good idea, and I'll try to do that.
All right, thank you. So I'm going to move the A71 amendment, which is my amendment, and I think it's relevant to the discussion that we're having, as a matter of fact. It should be in the packets. And so what this does is to flesh out a little bit more what the board will be doing, what it will be attempting to do when it does this negotiation with the health carriers, and what it would be looking for when it would be doing this negotiating. So this is under the section where the board has the power to select health carriers and health plans for participation that have met certification requirements. And then we're inserting, as you can see, that the board shall seek to contract with health carriers and health benefit plans so as to provide health coverage choices that offer the optimal combination of choice, value, quality, and service. And then we're inserting best so that these would be determined in the best interests of the individual consumers and employers within federal requirements. And then you can read the rest of it. And so this kind of goes along with what we've been dealing with here are kind of two different visions of what this thing is. On the one hand, you have the vision that this is just some kind of Travelocity where you have a nice website where people can go, and it's sort of a passive thing where insurance companies they meet minimum certification, they can put their wares on the website, and then consumers can go, maybe with a little help, and just kind of look around and pick something. The other vision, the one that I have and the one that this, and I think is in the bill already, and that what I'm doing is sort of just fleshing that out a little bit, is the vision that's been called active purchaser, or I forget what the other term is, but I look at it more like a buyer's club, as was discussed by some of the small business folks that were here yesterday and today. And that is a way for consumers, for individuals and small businesses to get market power, like the bigger companies would have, where they can say to insurers through this board, here are some things that we want to see. If you want to sell in our space and get the advantage of having access to all these new consumers with all their new subsidies, this is what you have to do, because we're looking out for the interests of the consumer, of the individual person and the small business that up till now has been at the mercy of the companies. And so this really just lays that out a little bit more clearly, I think, and so that's the amendment. So questions, members, or comments?
Madam Chair.
Representative Mack.
Trying to understand, just quickly looking at this, and I guess one question that I just noticed right off the bat in terms of, again, moving forward with, we're kind of still getting off on the right foot in committee. And I don't want to get us too far off here, but I'm noticing the timestamp at the top of the amendment. And I know we have a 24-hour rule, and I know that there's a few other amendments coming from Representative Loeffler that all have timestamps of this morning. And I know that our staff worked very hard yesterday with the revisers to respect and meet your 24-hour deadline, and we did so. And so I guess just want to put on the record, I'm just a little concerned if there's a double standard or how that's going to be handled going forward, Madam Chair.
Well, Representative Mack, this was the timestamp is for yesterday morning, so it easily meets the 24-hour. I was asking Mr. Bergeron, how did we not have the right? But no, indeed, it's correct. I got mine in with the same rule as everybody else. And just before we get to Representative Loeffler's amendments, I just want to be clear that she had hers done well ahead of the deadline, and it was simply staff resource problem that she was not able to actually get hers timestamped. So I consider that to be, obviously we're not going to penalize members because the staff gets backed up, and I hope that'll continue to be the rule. It simply wouldn't be fair. So I am certainly holding everybody to the same rule, including myself, just to be very clear.
Okay. Thank you, Madam Chair. And I was looking at the date on one on Loeffler's and then the time on yours. So I apologize. That was my mistake in looking at two at the same time. That's Representative Gottwald, who could never keep those two names straight.
Madam Chair? I'm sorry.
But I did just, to the amendment, thank you for clarifying that, and I just wanted to understand on Loeffler's amendments for today. If you could just, you go through in this amendment, on line 1.7 it says, in determining the best interest the board shall consider, and then give a list of the things that they should be looking out for. And number 6 is, it just seems to be left a bit wide open after you give some more prescriptive ways of going about it, that the board still has the ability to use any other criteria that they want in terms of determining what will or will not allow a plan. Could you just give the rationale for that? It seems, again, that it's not going to give the plans who are going to have to invest a great deal of money and resources to apply for something that they won't even, what could be a very subjective process, and I'm afraid that that's going to be a disincentive for some of these plans to even engage in the process, and then we'll end up with not having much competition within that exchange. And so I would just have concerns over leaving it wide open at the end of this amendment with the word other criteria included in there.
Well, Representative Mack, my purpose in putting forward the amendment is not to limit the board. And it's simply to give some guidance and some sort of examples of the kinds of things that I believe they would want to be looking out for the consumers who are going to be purchasing on the exchange. So the board is going to be limited. There is going to be some form of rulemaking, even though it might be expedited rulemaking that's in the bill now. So I don't think this is going to be standardless, and it's not my intent with this amendment to restrict the board from using criteria that may be developed later on. But so that's not something I'm attempting to impact that's already in the bill. I'm simply trying to sort of set the direction that this is clearly being done in the interest of the consumer and not in the interest of the insurance industry.
Madam Chair.
Representative Albright.
A question for you, Madam. In terms of, the vision that you cast for, what would be in the best interest of the board here, and I understand that, but pardon me, but I'm a bit Joe Friday when it comes to the facts. I need facts, and I'm not seeing that here on one particular point in terms of, in your opinion, as you would provide guidance to the board, or as the board, and this is where Representative Atkins and Ms. Malmuth might weigh in, is what would they deem, or what would you deem as an appropriate number of choices within the plan? What would you deem to be a full breadth of choice, given the fact that everyone around this table comes from a different fact set, comes from a different background, comes from a different health history? How are we to determine, or how is a board made up of 7 people with a majority of 4 able to decide what is in the best interests of everyone in the state, and just as an example, just the people around this table?
Well, Representative Albright, first of all, it's not everyone in the state, because we're not talking about everyone in the state who's going to be a purchaser on the exchange. So, we can just narrow it down a bit right there. And I'm not prepared to make a statement about how many it should be. I think that's, it depends on a lot of factors. But I think it is very clear that just having an endless number of choices is not necessarily real choice. And the example I like to use is I go to the store to buy a can of soup. If there are 30 brands, I may walk out without any soup because it's real. And I've done that. I mean, it's hard. When you have too many choices, it means that your opportunity cost in trying to figure out what the differences is very, very high. So we want to make sure that the people that understand and can look at the various aspects of products and the values and the costs and so on, and can give consumers meaningful choices so that they can actually go on the exchange, maybe with some help, maybe not, and make a decision and get the coverage that they need and not walk away without any soup, as it were. So that's what I'm trying to do. I think your question's a bit outside the scope of my amendment, because I'm really not trying to set that number or pretending that I'm...
Let me narrow the focus then.
Yes, Representative Albright.
Madam Chair, then, in light of the broad scope of this amendment, then, I have a question then for Representative Atkins. Is there a second bill coming that would define the rules of the road?
Representative Atkins.
Madam Chair, Representative Albright, yes. There is and it depends on which rules we're talking about. There's a market rules piece of legislation that is coming. It's referenced in the bill itself, you may have noticed, but we didn't want to tackle those issues in terms of what's going to apply to plans inside versus outside the exchange. If that's the piece that you're talking about, that is coming in a separate piece of legislation. As far as the rules of the road relative to the operations of this board, and selecting or not selecting certain plans, what Chair Liebling here is attempting to do is an effort at that. Up until now, we have not spelled that out in the language of the bill, with the idea being we want this to be kind of an entrepreneurial, nimble, market-oriented, and able to adapt to market conditions kind of board. I hope I answered your question. I didn't know which set of rules you were talking about, so I answered both.
I guess just to reference the analogy, thank you, Madam Chair, the analogy of going in a grocery store and looking for a can of soup. If I go into a grocery store and I'm looking for a can of soup, I very likely will not walk out of the grocery store without a can of soup because I'm hungry. And that's what the grocery store attendant, that's where the owner is entrepreneurial. He's going to provide me with choices because I might not want a certain flavor. I might want this flavor. And so to my point of even though those people that are inside the exchange, to limit the choices that are available within, I think does a disservice to the intelligence and the intellect and the consumerism of those people that are going to be in it. So I'll just leave it at that.
Well, Representative Albright, we're stretching the analogy a little bit here, but I didn't talk about different flavors. I talked about the same brand, different brands of the same flavor. So, I think that there are some choices that are meaningful. Basically, my basic point is there are meaningful choices and there are choices that really aren't meaningful. And we want to have choices that are meaningful so that consumers will be able to make a choice and make a choice that's really in their interest and feel good about their choice and have it be a choice that ultimately works for them. And if we simply have a website where just anything goes and you have to flip a coin to figure out why you should pick this one over that one, I'm not sure that we're well served. But I think we're way off the amendment, actually, which really doesn't address that. Who's there? Representative Gruenhagen.
Oh, thank you, Madam Chair. I need a little clarification here. I think during your presentation you talked about negotiation, and this kind of came up, if I understood you correctly, this came up yesterday too. It's the Department of Commerce that actually sets rates and approves plans, and so if they set the rate and approve the plan, I don't understand how the board is going to negotiate with the carriers. That seems like a contradiction in statute and in reason. I mean, is the plan going to have to work with the Department of Commerce and then after they're done go through another hoop, spending who knows what amount to work with the board? Or, it just seems duplicative, and I guess if there's somebody here from the Department of Commerce that can talk about how they're going to work with that board, it would be helpful to help me understand that.
Well, we'll see if there's someone who could do that, Representative Gruenhagen. I don't know if negotiate is really the right word here, but I'm looking at it this way. Plans are going to be able to sell their products in the general marketplace, but this is a special sector of the market that is there for a particular purpose. That's how I'm looking at it. Maybe somebody will correct me from the table, but so I think that I don't. It's maybe negotiation is the wrong word, but if the board is looking for plans that meet certain goals, it can say we're looking for plans that meet certain goals. If you want to have a plan if you want to sell in our special little market here, then you have to meet certain benchmarks. Now, I know we can't negotiate on rates, and certainly it's not in my amendment that we would negotiate on rates. That's not something that's going to be done. However, to say, we're just like if you're a larger business and you are not self-insured, but you want to go out and buy a policy. You say, well, here are our requirements, X, Y, Z. And then you would negotiate on rate. You'd say, here's what we're willing to pay. Come and give me your bid. If your bid meets my requirements, you'll have our business. Well, that is how I view this. If you meet our requirements, if you think you can, you want to develop a product that you think we might like, tell us what you're going to do for us, and we'll tell you if we want to offer that to our consumers. But I see we've got somebody at the table who can maybe give you the real answer. So, welcome to the committee.
That's Madam Chair. That's a tough introduction there. Madam Chair, Peter Brickwitty, Director of Government Affairs for the Department of Commerce. Representative Gruenhagen, to your question, the Department of Commerce approves, and as Representative Atkins has spoken about repeatedly during a number of hearings, the regulatory role of the Department of Commerce is not going to change with the advent of the exchange. And so the Department approves insurance products for sale in the state of Minnesota. We look at a number of different things, including rates. The department does not negotiate on rates or set rates. The company makes a rate filing, and then we evaluate that rate that filing to make sure that it meets the minimum statutory requirements for sale in Minnesota. So that would continue for any product that is offered by an insurance company for sale within the exchange environment. And so that will be the role of the Department of Commerce, is that we'll continue to perform that function as we have to the state.
Yeah.
Thank you,
Matt,
Representative Gruenhagen.
It is interesting, though. You said they don't set rates, but they do approve rates. So, I mean, it's kind of like you must give back and forth feedback to the insurance company as far as what their rates will be. And so anyway, it seemed a little bit confusing. But, hey, thanks for that clarification, and appreciate that. Thank you.
All right. Thank you. I'm sorry, did I miss a question there?
No, I just said let's eat the 30 cans of soup and then make sure we got the right one, okay?
Okay, yeah. Okay, that'd be very expensive, Representative Hagan. Okay, Representative Abler.
Thanks, I'm sorry I was late. I should have eaten lunch. I'm hungry now from all this soup discussion. Actually, I've made homemade soup, and you can look at it, and you can just tell it's not soup yet. You know, it's the carrots still look orange, and the little barleys are still floating, and they're not congealed with the celery. And actually, this bill is not soup yet, but someday it will be soup. And so, anyway, hopefully we'll like it when we're done. But Madam Chair, just a short comment. At the end of the day, this thing has to work. It has to draw enough plans and companies who actually want to compete in this market, and hopefully it won't just be two. And so I have a question that I held off yesterday, and then I have a question about your amendment. So the question promotes the question. And the question is this to the two testifiers. Representative Atkins or Ms. Todd Malmov, can the exchange do differential negotiations? It sounded like yesterday somebody said they could negotiate with a carrier about something. So could they negotiate with Blue Cross differently than they negotiate with Medica or some third party from outside the state in their process of deciding if they're going to be actively purchasing if they get to pick them or not?
Ms. Malmov, maybe you could set us straight about this negotiation thing once and for all. Please.
Madam Chair and Representative Abler, I want to give an example that I think will help people understand the negotiation concept. So I think as you heard from Mr. Brickwitty, the Department of Commerce would approve the rates that are filed, and the exchange has no ability to negotiate what those rates are. That's actually prohibited under federal law. We can't we can't negotiate rates. I think an example that could help understand how the selector could work is, for example, the exchange board could say that they are only going to accept plans that have a 90% medical loss ratio. There are what's allowed under the small group market is an 80% medical loss ratio, and so they could literally say that they're only going to accept plans that have a 90% medical loss ratio. That could encourage more cost-effective administrative costs and for those rates that are filed with the Department of Commerce.
Madam Chair.
Representative Abler.
Well, that didn't really help my question. So assuming the board goes forward, whether it's actively selecting or not, the board will be able to establish criteria in excess of state law or federal law if it chooses, based upon at least the draft we have. And so, but once they establish 90%, there was a talk that they could actually negotiate with carriers. That was somebody said that yesterday, and it might have been the author or somebody. But they can't have different standards for different carriers, right? If they have 90%, then they couldn't give somebody else 89% or demand somebody else pay 91% or have other criteria.
Madam Chair, Representative Abler, I apologize for not taking the question in the first place. I didn't actually know where you were going with that.
Oh.
But the short answer is no. They can't treat one under existing law. It doesn't even need to be spelled out in the bill. But you can't have an exchange board that's going to treat one versus one differently than another. But they would be able to talk with the individual plans about, so you could not, for example, say to Medica, we're going to favor you and let you have an 89% ratio versus somebody else that we're going to demand of it being 90%. I think that would give them a claim under existing law that they're being treated arbitrarily. It gets a little bit more complicated, though, when you start talking about, as I did, and I use the car analogy because I think people are more accustomed to that. If you're getting floor mats from one and then you go to another dealership and you say, well, they threw in floor mats over here, will you throw in, seat, an additional seat covering or something, whatever the case may be. But you can't arbitrarily treat one different than the other. Does that make sense?
Representative Abler.
A little?
What if you spill soup in the car, madam?
Yeah, I was going to use that, but I figured that would just go down a path.
Driving down, and you do want seat covers on floor mats if you're going to be spilling soup. Well, where I hope this thing winds up at is that it attracts people to come and that they'll invest $1 to $5 million per plan that they're going to have to put together to bring to meet the criteria. And if they go to that work, they can sell that product. And I personally don't care what the standards are because I don't have control over that. I do hope they're reasonable, and if it's 90%, I kind of like that. But so now I was more confused with the floor mat thing. So, but once you've established your criteria, you can't demand more out of them, or can you? So you were saying now I want seat covers. Everybody's giving us floor mats.
Representative.
And I'm not trying to be facetious, Madam Chair.
No, and perhaps I should stop using that analogy. I just didn't want to talk soup. No offense, Madam Chair. And let's start by working backwards. On page 8, there is on page 8, line 22 on page 8 talks about if the board were to act in any sort of arbitrary, capricious fashion, there's an opportunity for a contested case. So they can appeal that and argue that the board was acting in a way towards us that's different than anybody else. What I anticipate they will do, though, under the language as drafted in the bill, is they'll work with those plans to try to figure out which ones offer the best value. And the ones that offer the best value are the ones that are going to be selected. You can so you have the various entities, be it Medica, Blue Cross, health partners that come in, and they all have similar kinds of plans, but one is better than the other. And the board would have within its power to say, we like this version of the plan, and we're going to allow that one to be sold in our grocery store of health plans, if we're going to go back to the soup analogy, versus just taking every single plan and having hundreds and hundreds of products potentially. And the plans will dispute this. They'll all say we're not going to spend the kind of resources necessary to put together hundreds of plans to be sold. But I think the concern is that you have a reasonable number of choices, all of which deliver good value, and the ability to work with those plans to try to drive in that direction. And the amendment that the chair has offered, I think, starts to spell out what those sorts of things that the board is able to negotiate over. I'll stop using the word negotiate. What the board has an ability to talk with the plans about.
Madam Chair.
Representative Abler.
And I appreciate this. It just sounds to me like then they would be determining the best value. They couldn't. I'm uncomfortable if a plan meets the high standards that they've set as being really good standards that meet all your criteria, and then they're turned out. I think that's going to affect the competition. That's just my view of this, which is not the topic we're on right now. But I appreciate the negotiation thing. And so, but they couldn't say, well, if you throw in some car seats, then we're going to put you ahead of the people that have. They can't do that, right? They just get to pick. If there's an active purchaser and they're going to decide who gets the award, they're going to have to determine the people that have thrown in the most bells and whistles for the price. And then they would elect that, but they couldn't give them a hint that we threw this and we're going to cover you too. Is that?
Representative Atkins.
Madam Chair, Representative Abler, I'm not certain that I'm completely tracking. I think the analogy that, or the example that Ms. Malma used earlier about setting the bar for at 90%, for example, that went perhaps even beyond what the certification level is to just get into the exchange, but then had further demands on top of that, is probably a more likely scenario than what I've described. But you've identified an issue. I'm not making light of it at all. I think there's a school of thought that says just set the bar very high, and if you meet that very high bar, whatever it may be, as set by the board, that might be enough to get you into the exchange with no further, whether it's discussions, negotiation, whatever we want to term it. So I get the concern.
Madam Chair, I do have a question to your amendment coming through all this.
Okay, please.
But I think it's going to come up later anyway, just how we pick who's going to be in, so it's germane to the debate. But I think it shows some of the complexity and some of the problems with allowing a board to, in a qualitative way, choose one over another that may actually be quite close to the same. So to your amendment, Madam Chair, I was curious. I think you're on the right track of trying to at least give some parameters for what they can talk about. And I don't care if you fix it now, but on line 1.2, when the phrase seek to, and then later on it says so as to, an optimal combination of, those sound really much like a Betty Crocker sort of a thing, and a pinch of this and a pinch of that. And I'm sorry that we're doing the analogy so far, but I think if it were if it were more clean and said, if you didn't say seek to, but the board shall contract with health carriers and health benefit plans to provide health coverage choices that offer choice, quality, value, and service. It becomes clean and gives them a task, and it gives them topics to work on that at least people can shoot for. When you get into combinations, then you get subjective, and you'll have a lot of lawsuits and more expense, which will be borne by the fully insured market. So if I would amend it, I would actually take those words out, but I didn't talk to you about this ahead of time, so if you're interested to make it cleaner, I think that would, get you where you want to go with some focus.
Thank you, Representative Abler. I certainly will. I guess what I'd like to do is vote on the amendment, but if you were on to keep working on it and write out a suggestion for me, I would certainly consider that. I don't have any problem with working with you on that, so thanks for that suggestion. So, members, we have, let's see, I've got Schumacher, Zerwas, Albright, and Mack, and I don't know if those are all to the amendment. Those are to the amendment? Okay. Schumacher.
Well, thank you, Madam Chair, for that. And for this amendment, I just have a couple of questions about the definition of some of the points that you have on there. One bill that I worked on last year was the critical access nursing home project and trying to get some low-rate nursing homes a little bit of extra help with things. And we had put in criteria similar to this that wasn't well defined in my mind and the department's mind, and the department got to place that where they saw best fit. And those facilities that they were awarded weren't anywhere near where I expected them to be. And so now I'm on this kick about definition on criteria and that sort of thing. It's part of my motivation now. And so I was just wondering with basically the criteria there, what you saw as some of the definition, basically from line 1.7 through, but really lines 1.8, the value, line 1.11, the ensuring access to care, in particular, just what your definition and thoughts were to those points. Thank you, Madam Chair.
Well, Representative Schumacher, I'm really just trying to give a direction here, and I'm kind of purposely not really defining it because it's really not my intention, as I said before, to limit the board. But what I wanted to do was make it really clear what we're trying to do here. So it is a bit more kind of goal language, and I'm not trying to restrict the board. So maybe it's a little different than what you were trying to do with the nursing homes. I'm really not trying to set down particular criteria. It just says best interests and the board shall consider. It doesn't say how the board should weigh these factors. It doesn't say that, one is more important than the other or anything like that. It's just really meant to be kind of a directional statement to make it really clear that the purpose of this entity is not just to be a classy website where insurance companies can lower their costs, their sales costs, basically. That's really my direction here, but I appreciate your comment.
Thank you.
Yeah. Representative Zerwas.
Thank you, Madam Chair. Question for Representative Atkins. And I was a little bit later on the list, so I apologize for going back to the car analogy. But in your analogy, you talked about you set your price, and then you're looking for the add-ons or the throw-ins, the mats, I got a remote start in mine, and it's probably the best thing I negotiated in my car. But when we're looking at this, the 90% was put on as a possible add-on that we could do. Let's talk about what are some more specific add-ons that the Health Insurance Exchange is going to be looking at. We're not talking about the pricing, we're not talking about the rates. So it's this list of add-ons, and I guess we have one example of one. Let's list out half a dozen.
Madam Chair. Representative Zerwas, let me give you two. I don't necessarily have 6 really good ones, but I got 2 that I think are pretty good. One, and I'm going to stay away from that car analogy altogether. But one would be that, for example, that each of the plans is just demanded to provide in the market their most popular product. Whatever is outside the exchange, they have to offer that if they're going to participate in the exchange. That goes beyond the certification, goes beyond what Commerce demanded. It just simply says that they have to provide their most popular product. Another example might be that a particular plan has 17 different products all within the silver or within the bronze, and they're all really close to one another with very, very minute differences between each one. They might say that that's unrealistic. Perhaps it is. But under the language of the bill, it says that the board could go to them and say, listen, limit it to 2 or 3 or whatever some reasonable number that have a meaningful difference between each of those product offerings. Those are the sorts of things I believe that are being contemplated.
Thank you. Representative Albright.
To that point, Representative Atkins, if you're providing their most popular product on the inside of the health insurance exchange and doing that same thing on the outside, if I'm a marketer of a product, I'm going to gross up the cost of that product inside the health insurance exchange by 3.5% because that's the premium tax that you're putting in the bill. So by law, doesn't that necessarily mean that the private policy is going to cost 3.5% more than it would otherwise cost?
Representative Atkins.
Madam Chair, Representative Albright, keep in mind that the exchange, the marketplace, is actually going to perform some of the efforts, some of the key work necessary to purchase that plan in the first place. Things that cost a significant amount of money. Determining eligibility, for example, doing the actual enrollment. So if I don't, maybe the plans could come down and tell us exactly how much they pay the people that do that. But you've got 2 things at play. One is those administrative costs that are going to be handled through the exchange. The second is the ability to sell somewhere in the neighborhood of 1.3 million people worth of plans, 300,000 that currently are uninsured. That ability to sell that number of plans and make the money that you're able to do off of that, I don't think there should be a considerable difference.
Madam Chair, just one follow-up.
Okay, Representative Albright.
Just one. Thank you. So if rates are tied to benefits, and you're going to, the HICS or the board is going to determine what is better, then how will you know what the rate, when that rate is appropriate and effective? If you don't have, you go back to what Representative Abler said about negotiating, features and benefits. It seems to me like there's this give and take between what is provided and what is paid for, but I don't know how a board of 7 people with the conflict of interests that are put into this are really going to appreciate value-added service and or appropriate thresholds for each one of these strata. Could you speak to that?
Madam Chair, Representative Albright, I can try. I'm not exactly sure that I'm tracking with where your question is going. Rates are tied to benefits, but they're also tied to a lot of other things, like administrative costs and, in some instances, performance with respect to investments, competition that will be more vibrant within a market like this. So I think all of those are cost drivers that will impact what the rates will be. And the opportunity to sell in this market and have 300,000 more lives that you can insure, I think is a market that folks are going to want to be very competitive in. And hopefully that drives down the cost of the rates in the market as well.
Okay, Representative Mack.
Thank you, Madam Chair. And just to the amendment briefly, I guess my only concern is I understand what is trying to be accomplished through this amendment. I guess my concern is that this will further control who can and cannot sell within the market. And these are good goals, but they don't have measurable outcomes. They're not very concrete. It kind of adds to my concern that plans will be very gun-shy to even go about the process of trying to get into the exchange because of the level of subjectivity that's going to be involved. I think we need a selection process that's transparent and a bit more concrete. And I understand that there's going to be a second bill coming. It's troubling that we're going to be passing this initial bill creating the exchange and this enormous change in how we currently delivering many of our programs without understanding what that criteria is going to be going forward and without giving our plans the ability to understand that process and how they will or will not be let in. And so to me, I don't think that this amendment really creates a great deal of comfort in terms of how that's going to move forward. And I guess, Representative Atkins, if you want to speak to it, you can or cannot. But do you have that concern, or do you see a situation here where, because of the subjectivity and lack of concrete outcomes and specifications that plans can measure up to, that they will in fact be disincentivized from getting involved in this process?
Representative Atkins.
Madam Chair and Representative Mack, I appreciate the question, because I do have the concern. I do want to point out one. I referenced earlier a market rules bill that will also be traveling, and that's separate from the criteria that the board would be using to figure out which plans to select from. That's entirely separate. It will deal with the products in and outside of the exchange and the market rules that apply to products inside versus outside the exchange. But as far as what criteria would govern this board and the selection process that they use to, for example, demand that plans offer their best product, or plans offer, if you're going to put 17, instead you narrow that down to 2 or 3 or 4. I think that's perfectly appropriate for the legislature to be working on in the context of this bill. In addition to an arbitrary and capricious standard, which is already in the law, that it's inappropriate to take that approach. What the chair has put forth in her amendment, I think, are good guidelines to the extent that the board is going to narrow down from the products that are being offered some direction that it's given the board. I would hope that would be the kind of thing that they would already want to be doing. But there's certainly nothing wrong with this body giving some direction to that and giving some certainty then to the folks in the who may want to be in this market, specifically the plans themselves.
Just a really brief follow-up, Madam Chair.
Okay, just real brief,
Yep.
Representative Mack.
Just to that last statement, if I'm understanding you correctly, and correct me if I'm wrong, then you're open to, down the road, maybe building in some more concrete, measurable criteria in which the exchange board would operate under, that the legislature could approve, if I'm understanding that you're open to that conversation and possibly changing this bill to build that in.
Representative Atkins.
Madam Chair and Representative Mack, I'm open all throughout this process. I've learned more about my bill as a result of the testimony that folks have provided. I'm open today, Representative Mack. I think what the chair has talked about, some of the criteria, affordability and value, promotion of high-quality health care, those are things I should have had in the bill in the first place. And so as we go through the process, and we've got several more committee stops as we set a record, I've asked Mr. McCormick, by the way, as a quick aside, what's the most number of committees a bill has ever stopped at? Because whatever it takes, I'm going to get that record this time around with this bill. But I absolutely am open to, and I appreciate the chair's efforts to start to lay out some of the criteria.
And so I'm going to move ahead, members, and take a vote. There's Representative Gruenhagen is on the list. Is it to the amendment, Representative Gruenhagen? Because we have 5 minutes. We're going to vote on this amendment. We're going to be coming back, and we have quite a stack of amendments to go through. So go ahead, and then last word, and then
I
we're going to vote
understand,
on the
Madam
amendment.
Chair. This is one of the most important changes in the last 40 years to health care, though, and it will affect. No, not this, but the process.
I thought we were talking about the soup.
Yeah.
Wow.
This is part of the ingredient, but no. As long as we had the testifier April here, and I forgot your last name, I apologize for that. But these are fine-sounding words. But one of the things we've seen in the Massachusetts plan is that you have bronze, silver, gold, and platinum, and with no underwriting and no pre-existing, we see a concentration of people with high claims in the plan that has the best benefits. And, of course, people with better health take the lower benefits. The result is the high claims all concentrated in just a few plans corrupts that plan, drives the rates up, and ultimately the carrier leaves the market. Now, I know you explained there's a mechanism in the federal plan that addresses that. Just explain to the committee a little bit how that mechanism works. And does it have a proven track record of actually accomplishing what you say what you say, or is it just based on theory?
Yeah, and I'm just going to ask, do you have a really short answer? Otherwise, I'm going to ask you to hold your answer, and we're going to vote on the amendment. So do you want to answer first, just very quickly, if you can?
Madam Chair, I don't know if there is a short answer, but I'll try to do one quickly. This is one of the difference between Massachusetts and under the ACA is the risk adjustment provision, which essentially requires that plans set premiums based on a standard population for any of the metal levels. So they can't set premiums based on past experience within any particular product. So they can't price it based on sick people just congregating into one plan. The point of risk adjustment is that it will look at the risk mix within each of those products, and those that are riskier will take funds from those plans that attract less sick individuals and transfer that to the plans that have the higher risk individuals.
All right, thank you. So I'm going to renew my motion. I'm moving the A71 amendment. All in favor, please say aye.
Aye.
Aye. All opposed, no.
No.
The motion prevails. The amendment is adopted. We can go on to the, let's see, Representative Loeffler, you have the, you have one that you think we could do just in a very few minutes, or that we could start, or maybe it wouldn't make sense to do that. Your choice.
Madam Chair, if we're supposed to be done at 3:45, I suspect people will have questions, and I'd really like people to have a chance to make sure they understand it. So
okay.
I don't know that there's one that's just a quick cleanup, because the quick cleanups have been merged with other things.
Okay, so that being the case, members, we're going to recess to the call of the chair. We'll be back in this room approximately 8 o'clock. 8 o'clock, we'll say, unless this State of the State goes later, then we'll be 15 minutes after the State of the State is ended. So we are in recess.